in many of these distant metastasis patients, we use radioactive iodine. And we've typically used a lot of radioactive iodine. And when it wouldn't work, we would use more radioactive iodine. Dr. Naifa, you're as guilty of this as I am.
No.
No, not so much?
No,
Help me understand, when do we say enough with radioactive iodine? When is somebody RAI refractory? From a, not from an academic guidelines, but from a real practical standpoint.
Yeah.
When do you say, I'm done with radioactive iodine?
Yeah, so that has shifted a lot of how we've changed how we've thought about that over the years in terms of what is truly radioactive iodine refractory, or when does radioactive iodine truly work, or when should we try it again? And so in general, I mean, the way that I practice, I think, is similar to a lot of folks on this table here, is that we'll probably give it, the patient has just had surgery, we know that they're high risk, that they need their radioactive iodine, we'll treat them with one therapy. And then look at their post-treatment scan, which is going to be very important because that's our more sensitive way to look at if their disease takes up radioactive iodine or not. And if I knew, let's say from a CT chest, that they had pulmonary nodules or that they had a spine, and I knew that those were definitely thyroid cancer metastasis, but their post-treatment scan doesn't light up, I'm calling that patient from the beginning radioactive iodine refractory. That tumor biology is not going to change 2 years from now when they get a new MET, that it's going to be sensitive to radioactive iodine. So I'm calling them from the get-go. Sometimes you'll treat a patient in that post-operative setting, that initial dose of radioactive iodine, you don't see anything on the scan, they don't have much thyroglobulin, so you think that they don't have any disease, and something pops up later. In that case, you don't necessarily know if they're radioactive iodine sensitive or not. You're guessing, if you were a betting person, that it's probably refractory to radioactive iodine, but you truly don't know. So it is worth looking and taking a look with either a diagnostic scan or even giving an empiric dose. It depends on your philosophy. Give an empiric dose of radioactive iodine, but look at that post-treatment scan. If you have any thyroglobulin or any lesions that you're seeing on a SPECT or a CT scan that you know are thyroid cancer and they're not lighting up, call them radioactive iodine refractory and stop. Don't give them a 500, 600 millicuries of radioactive iodine before you call it.
Yeah.
Just once.
Marcia, we share a lot of patients together. Most of our emails is, do you think this is already reactive? Or you send them to me so you think they're already. What do you need to know to call somebody RAI refractory?
So I love it when I have a wonderful history and there was clearly nodule there, radioactive iodine scan was not positive, end of story. Yeah. Where I'm always emailing you to get the information on is now a patient had radioactive iodine. They maybe had a little bit uptake or didn't have uptake, but now they've gone for 3 or 4 years and they've been fine. So what I think we always have to remember that radioactive iodine actually is cytotoxic. It actually does kill the cells. And so if they look like they've gotten, in my opinion, that would be a clinical benefit, I'm questioning whether or not that will happen. It's not uncommon that an oncologist in this country will get sent the patient who may have had 1 or 2 doses, but you really need to know the context. You need to know, obviously, what Naifa just said, but you also need to know, how long they went between radiation doses. Did they get a benefit? And so I often will, if I can't glean that from the history that I've gotten or the records of the timing, I'll just usually email you because as the person who is treating the patient, you usually can tell me, oh yeah, at this time they had this and that ends the story. And I'm always very thankful when you get back to it. It saves me a lot of grief. Yeah. If, however, it's not uncommon that sometimes we don't know, it doesn't really hurt to stop and say, let's just make absolutely sure and do a diagnostic scan and just check it. The other side of the coin, though, I think is interesting, is that historically we get a lot of patients who have had all of these radioactive iodine scans and not scans and scans and uptake or not uptake, and it's responsive and there's no uptake. And then, they had a CAT scan. And it turns out they've got 100 nodules. And now I'm like, oh, shoot, but when were they there? Yeah. So I think that we're evolving, and there's been now a paper out where we've talked about this, that I think it really benefits patients, especially if they have the higher their thyroglobulin is positive and the uptake scan is negative. Please get a CAT scan right after the radioactive one with contrast. Because if you do it after the iodine, you're not going to give them iodine for a while. You can get the contrast and at least get one scan, because otherwise you're only going to see what you're looking for and you're not going to see what we need to know. And so you need to have that complementary.
It's that structural piece you guys
really important. I know, at least once.
I mean, there's definitely also cases where we really don't even need iodine or do an iodine scan to know they're refractory. So we know that the chance of them being radioactive iodine sensitive is inversely related to death avidity on a PET scan. And we've had a few patients, especially with Hurthle cell, where they've had FDG-avid tumors that were SUVs were 50, 60, 90, and there really is like absolutely no reason to even go through a radioactive iodine scan for these patients, that they're not going to have a benefit for it. And we've been putting more and more into our studies that these FDG-avid disease really doesn't even need to be proven to be RI refractory through radioactive iodine, that alone is necessary. And it's also sometimes even with these very poorly differentiated thyroid cancers that they even might be positive on the RAI scan. But Mona Sabra put out a paper where it really showed that if you give these patients radioactive iodine, they really don't have any benefit. So I think you have to go beyond just what the iodine scan shows or having to do an iodine scan, that there's other factors that are out there that really tell us this is a person whose disease really shouldn't be getting iodine, and we really need to be looking at systemic therapy right away.
It's complicated because we can see, you can get enough radioactive iodine in a tumor to make it positive on a scan, but still not be tumoricidal.
Yeah.
So those are
Yeah.
difficult. Frank?
Yeah, no, I was going to say the same thing that Eric did. Sometimes these tumors, you can just tell the aggressive nature of the tumor, the extent of disease, and you get a PET, and the PET's positive. So it's instead of sending them back to you for RAI treatment, we just deem those people refractory up front.
It's a combination of functional and structural. Frank, you mentioned.